Good evening, everybody. Thank you so much for being here this evening. So probably there are some other doctors coming. So I just would like to introduce you this webinar. I would like just 2 minutes to introduce you, Professor Cagnacci. Professor Cagnacci, as you probably already know, is a full professor, chief of the obstetric and gynecology clinic in San Martino University Hospital in Genova, Italy. And he's a full professor, and he was also studied and PhD in perinatology at the University of Perugia as well. Most of you probably already know that he wrote a lot of publication that you can read on Climateric Review. That is one of the most important one. And this evening, we invited you because he has some good news for us, as you probably you received the brochure about the latest updates on the application of Cares Flow in cases of GSM and incontinence in breast cancer survivors. So I just would like to inform you that we will record the webinar, and after Professor Cagnacci's speech, we will let you have 10 minutes for general questions. I just ask you to please you just to mute the microphone, and thank you so much for everybody, especially for Professor Cagnacci. Thank you so much.
Thank you so much, Nives, for your presentation, your kind presentation. I welcome everybody. I'm very happy to be here to share some of our data on breast cancer survivors and Cares Flow and treatment with Cares Flow. I'm going to share my presentation, and I hope you see it. And yeah, I would like to start. Before arriving to the final data that we have, I would like just to introduce you something about vaginal atrophy, the genital urinary syndrome, and the different treatment that how we can perform a diagnosis and the different treatment that we may have. And where the treatment that we can share, we can put together with Cares Flow. You know very well that vaginal atrophy is a disease, a disturbance that is included now in the genital urinary syndrome of the menopause since the consensus conference in 2013, where the GSM was defined as the presence of three main symptoms, genital symptoms like dryness, burning, or irritation, sexual symptoms, lack of lubrication, dyspareunia, impaired sexual function, and urinary symptoms, urgency, mainly a recurrent urinary tract infection. Now, if we have the aim to define the epidemiology of vaginal atrophy, clearly is not clear what kind of symptom or sign we may choose to define the epidemiology of vaginal atrophy, because you know, we have different symptoms like dryness, dyspareunia, burning, itching, different signs: dryness, pallor, thinning of the mucosa rugae, loss of elasticity, fragility of the mucosa, petechia, And then we have objective signs, lack of the maturation of the epithelium, or the vaginal epithelium, or the increase of pH. So what kind of what do we choose to perform a diagnosis of vaginal atrophy? In our country, we performed an epidemiological study on the prevalence of vaginal atrophy, and we used to perform this epidemiological study that was performed both in postmenopause and in menopausal transition, the association of three main markers. One symptom that the most prevalent was vaginal dryness, so we choose vaginal dryness as a symptom, associated with the APH measured in the vagina above 5, and together with another sign, objective sign, observed by the physician, like dryness of the vagina, the pallor of the mucosa, or whatever you see there, the different things. And with the association of these three main symptoms, we obtained this epidemiology. And you can see here that vaginal atrophy is very frequent. Basically, in the postmenopause, we have almost 80% of women with vaginal atrophy. 1 year after the menopause, we have almost 65% of women with vaginal atrophy to reach values above 80%. But also in the transition, the menopausal transition, we may have vaginal atrophy. 80% of women in the age of between 40 and 45 have suffered from vaginal atrophy. And this percentage increase to 50-60% around the menopausal transition. So this is a very common symptoms that we may have to deal with. The important things that when we start to treat these women, well, the diagnosis is basically, is it difficult to make the diagnosis and to start treatment? No, it's not difficult. We don't have to perform many evaluations, because you see here that among the women that said to us that they were suffering from dryness, vaginal dryness, 97% of them had also a diagnosis of vaginal atrophy. So the symptom, vaginal dryness, almost always identify women with vaginal atrophy. And by the way, we don't treat vaginal atrophy, but we treat the symptoms. So every woman that comes to us with a symptom like vaginal dryness should receive a treatment. By the way, dryness, vaginal dryness, is also referred to by the women as the most bothersome symptoms, more than dyspareunia, more than itching, more than burning, more than dysuria. Vaginal dryness is the most bothersome symptoms referred by the women, and also one of the most bothersome symptoms among the menopausal symptoms. You see, the most bothersome symptoms of menopause in this Italian survey, 40-45% of women says hot flashes, but then we have 20% of women says vaginal dryness, and another 20% that says urinary disturbance. So the genitourinary urinary syndrome is very important. It's very important for the women in the menopausal transition. Then we may have also other way to perform the diagnosis. Many of you knows the VHIS score that you see is very complex. It's very complex. You have to evaluate elasticity, fluid secretion, the different pH, epithelial mucosa, moisture. Clearly, this helps us to define the degree of vaginal atrophy, but is not so important to start the treatment of vaginal atrophy. Now, when we clearly the treatment for vaginal atrophy and genitourinary syndrome start with try to improve the dryness, vaginal dryness. So the moisturizing agent are the first line treatment along with the lubricants to favor sexual intimacy and sexual intercourse. Then we have also the possibility to stimulate to stimulate the epithelial maturation with medicine that act on a receptor, on sex steroid receptors like estrogens, but also with the progesterone is DHA, or also with the phytoestrogens that go to stimulate the estrogen receptor in the mucosa of the vagina. And also by the oral route, we may use ospemifene that also is a SERM administered by orally that go to stimulate the estrogen receptor on the vaginal mucosa. But we may also recur or use physical method, and you are familiar maybe with most of these methods, with the laser, with the radio frequency, with the electrophoresis. But in our last recommendation that we will publish, that will be published in the next months, the Italian Society of Menopause, we added also vaginal oxygen plus hyaluronic acid. And this was based mainly on several considerations. We already saw the presentation of this webinar with the small movie showing the advantages and the mechanism of action of hyaluronic acid. Hyaluronic acid, have different molecular weight, and if you choose a big molecular weight that it does not penetrate the mucosa and it stays on the surface of the mucosa. And if you choose instead a very low molecular weight like 20 to 290 kilodalton, you may have molecules of hyaluronic acid that enter inside the mucosa and go to stimulate the collagen cell to produce collagen and increase the humidity and the trophism of the mucosa. But what we think is more important than that hyaluronic acid is the oxygenation of the mucosa. And we have many data from the literature showing that when you increase the tension of oxygen inside the tissue, you have a production of collagen, increases the production of collagen, and you have a more rapid improvement in the healing of the tissue. And also when you increase the content of the tension of oxygen within the tissue, you have an increase of vascular endothelial growth factors. So basically you have an increase in the vascularization of the tissue, and the vascularization of the tissue clearly improves the quality of the tissue, bringing growth factors and nutrients for the tissue. So we think that maybe it's more important the oxygen than the hyaluronic acid in improving the quality of the vaginal tissue. Now, this treatment was firstly proved, the efficacy of this treatment was firstly proved by Condemi that you saw in the movie, in the original movie, and he decided and he set the treatment, the protocol. So 5 treatments at 2 weeks intervals, with the length of each treatment of about 15 minutes. And in the first 10 minutes, we deliver through the cannula only oxygen, and in the last 5 minutes, oxygen plus a hyaluronic acid solution. They proved that this is good for the vagina to treat the vaginal atrophy in normal menopause, in women in physiological postmenopause. Then, after this evidence, we thought that maybe this treatment was a good treatment also for breast cancer survivors. You know that breast cancer survivors cannot use or systemic hormone therapy. They have difficulties to use local therapies, local hormonal therapies. If they can use it, they can use only after the end of their treatment, the adjuvant treatment, oncologic treatment. So in that period, in this 5, 7, 8 years after the surgery, they are clearly hypoestrogenic and they suffer, as you can see, more than all the other people with cancer of gynecological disturbances, mainly on vaginal or disturbances linked to vaginal atrophy. So the first study that we published in 2023 was the use of vaginal oxygen plus hyaluronic acid on genitourinary symptom of breast cancer survivor, and mainly on vaginal atrophy. We selected 40 women, survivors from breast cancer, that were on endocrine therapy, so mainly on aromatase inhibitor or GnRH anagrowth plus tamoxifen. You see the age was 46. They were rather thin, BMI around 18, and were in a stable relationship. The stable relationship is important because clearly it means that they have a partner, and the effect of the vaginal atrophy and the consequences of vaginal atrophy may have an influence on their sexuality, on their relationship with the partner. And you see here the result of our treatment. We applied the same treatment as described originally. So one application every 15 days, 15 minutes of application, 10 minutes only oxygen, and 5 minutes oxygen plus hyaluronic acid. And you see the vaginal health index score. You know that the cutoff with this score to define vaginal atrophy is 15. So when you are below 15, you can say that we have that the human has a vaginal atrophy, and then when you are above 15, there is no vaginal atrophy. And you see that at the beginning, the mean values of the vaginal health index was very low, was 9.45, so well below the cutoff for vaginal atrophy. But we have an immediate recovery of the quality of the vaginal mucosa, because after 15 days, only after the first application, we reached the 11.8 the vaginal health score. Then after 2 applications, 13, and at the third application, we were in the cutoff to define vaginal atrophy, and then we went above the cutoff. So we had a very good response in the vagina of these women. If we express this in terms of vaginal atrophy, you see almost all the women had vaginal atrophy at the beginning, 100%, and then we have a progressive reduction of the women in which we may perform a diagnosis of vaginal atrophy, so 80% after only 1 application, 55% after 2 applications, 45% after 3 applications, 25% after 4 applications, and then we reached 80%, only 80% of these women did not respond effectively to the treatment. Well, we may say that all the treatment for vaginal atrophy do not reach a complete response. Even estrogens, even vaginal estrogens, even systemic estrogens have a part of the women, a partial response or even no response in terms of about 20-25%. Here again, you see the improvement of the vaginal health index, and below you see the reduction of pain during intercourse, so a reduction in the VAS score for dyspareunia, and also a reduction, marked reduction of the symptom of burning. So we have a complete response, a rather important response in all the aspects that we evaluated. But the most important thing is the lubrification of the vagina. So the improvement in dryness. Improvement in dryness that is, as I told you, is the most bothersome symptoms and the one that also conditionated pain during intercourse. And you see here that after one application, the score went up to 5. The maximum score is 5. And you see that the dryness improved after one application, after two applications, after three. And at the fourth application, we already reached the maximum values of lubrification. Maximal values of lubrification. That is a very important, because lubrification, as I said you before, dryness is the most bothersome symptoms, but is also the one that influences more than others the sexuality of the women. Sexuality, female sexuality, is the other part of the genitourinary symptom. And you see that sexuality is reduced, all the aspects of sexuality are reduced by vaginal dryness. Vaginal dryness reduces desire, reduces arousal, reduces clearly lubrification, reduces the capacity to reach an orgasm, reduces the satisfaction with the intercourse, and clearly increase dyspareunia. So to improve vaginal dryness, improve all these aspects of sexuality, female sexuality. And indeed, when we look at the female sexual function index, if the different items, you see here that from pre-treatment, that is the black column, we had after at the third evaluation, at the end of the evaluation, visit 5, and then 1 month of follow-up, we have an increase of all these different items of sexuality. So we had improvement in desire, in arousal, in lubrification, in orgasm, in satisfaction during intercourse, and pain. So we not only improved the quality of the vagina, we improved the lubrification, and we improved the sexuality of these women. These women were not selected for as having urinary disturbances. We had they did not suffer for severe urinary disturbance. As you see here, the urinary distress inventory, the scale goes from 0 to 100, and you see that these women suffer from mild urinary disturbance. Yet, when we treated these women with Caris Flow, we had an improvement of urinary disturbances that was progressive and improved after 5 applications. So in another, after this first evaluation, we performed a secondary evaluation just focused on urinary disturbances of breast cancer survivor. This is not the main topic for breast cancer survivors because maybe they are young, they still don't have a very advanced vaginal atrophy or not persistent in the long-term vaginal atrophy, so the urinary syndrome in the part of the urinary disturbances is not so advanced as in older people. But yet we selected all these women that at least had some disturbances, some urinary disturbances. There were 85 women, and you see here the characteristic of these women, a mean age of 48, and most of them were on adjuvant therapy, some on tamoxifen, and some on aromatase inhibitors. In these 85 women, we confirmed that the effect of that was previously found in 40 women. Now we doubled the number, and still we saw the effect on the vaginal health index. You see here that from 99.7, the vaginal health index went to 16 as previously reported. But when we look at the urinary distress inventory, also we saw a significant reduction as previously reported. But here we implemented the study with more greater number of women, specifically investigated this aspect. And we saw a reduction of urinary distress inventory. As you know, the urinary distress inventory basically investigated the three aspects of urinary disturbances: the irritative symptoms like hyperactive bladder and urinary incontinence, urgency urinary incontinence, the stress symptoms, so the leaking of urine during stress. There are two questions about this, and then obstructive and discomfort symptoms like symptoms of occlusion due to prolapse or discomfort during urination. And you see here that the symptoms that more significantly improve during carriage flow are the irritative symptoms. You see from 9.2, we reach values of 5.5. We have less, and also we have less effect on stress symptoms, so leakage of urine during stress, and little bit less efficacy on obstructive symptoms that are mainly due to prolapse or defects, pelvic defects. Here you see the effect. We had basically women with a mild urinary disturbances. You see the cutoff there, the UD score on the left from 0 to 100. When we are below 33, we have mild symptoms. From 33 to 66, we have intermediate symptoms, and the severe symptoms are in women with a score above 66. So as mean, we had women with a mild urinary symptoms. Yet there were some women that were suffering from severe symptoms, and about 14% of these women suffered from severe irritative symptoms. Then there were the stress symptoms were around 9%, along with the obstructive discomfort symptoms, severe around 90%. And what you see is that the marked reduction in the prevalence of irritative symptoms, mainly during the utilization of Cares flow. All the symptoms decline, all the severe symptoms decline, but the most relevant effect on irritative symptoms. And also women without symptoms, the number of women that were without symptoms, without mild symptoms, so women without or with mild symptoms increased from, for irritative symptoms, increased from 55 to 85%. So we have a good response mainly on irritative symptoms, on uh, urinary incontinence by urge urinary incontinence or hyperactive bladder disturbances. We also noted that the best response was obtained in women on aromatase inhibitors. You see here that the decline, the maximal decline, I will show you here. I'll take this pleasure. You see here that the maximum decline that we observed in the UD score, so in this urinary distress inventory, was obtained in women that were using aromatase inhibitors, because clearly these women are fully deprived of estrogens, and the effect are very, very evident in these women. Whereas the effects were not evident in women on tamoxifen, because these women are not really estrogen deprived. Yeah, they are estrogen deprived on the breast, but tamoxifen is a SERM, so it acts as an agonist on the endometrium, and probably it acts as an agonist on the bone, and probably also on the vagina and the urethra. So the effect on mainly in the urethra. So the effect on tamoxifen were not so evident with the Caris flow. Whereas in women with aromatase inhibitor, we had a very good improvement. One of the questions that remains is in this group of people is for how long it lasts does it last the efficacy, the effect of the treatment. So we performed in other studies. We followed 65 breast cancer survivors, you see, for 12 months. For 12 months after the treatment. So this are the characteristics of the women, age 48, body mass index, they were still thin, parity, number of pregnancy, whatever, and the adjuvant therapy, the 87% were, almost 90% were adjuvant therapy on tamoxifen, aromatase inhibitors, or generate analog plus aromatase inhibitors. And what we found is this. You see, this is the vaginal health index modification during treatment. So this is baseline. This is the 5 after the 5 application. The score of the vaginal index score went above 15, and then we have the 1 month follow-up, the 3-month follow-up, and the 12 months follow-up. As you can see here, there is a progressive slight decline of the effect, but at the end of the 12 months, we still have a value that is well above the original baseline value. And here you see the data from 9 to 9.6, you go to 16. After 1 month, you are still above the cutoff. After 3 months, you are around the cutoff. After 12 months, you are slightly below the cutoff for vaginal atrophy. What the hydration, however, persists significantly, the epithelium also, and you see here basically what we lose, what we do not improve is the pH. We don't we are not able to decrease the pH of these women, but we conserve a little bit of all the other effect of the vaginal health index. Clearly, the conservation of the lubrification, the hydration, has a positive effect on the sexuality of these women. So, in spite of a slight decline of the vaginal health condition, still you see that the sexuality of these women remains at the levels that were achieved at the end of the treatment. You see that here the score from 10 went up to 15 and then remained around 14 after 12 months. So there is because there is a conservation of the lubrification, there is also a conservation of the sexuality of these women. Clearly, is not an optimal sexuality, but we have to think that these are a particular set of women where the preoccupation for breast cancer is very important, and is the main dominant thought about is around survival, around the preoccupation of the recurrence of the cancer. So sexuality cannot be clearly optimal. Yet from gynecological point of view, we improved the condition to give these women a better sexual life. Also, dyspareunia, you see here a burning where clearly improved during the treatment, as we showed previously, and still did not return to baseline values after 12 months. So we have a maintenance of the effect of the treatment in the long period, or a partial maintenance, whereas we lost completely the effect on urinary disturbances. You see that the urinary disturbances were decreased from 20 to 14 after a month. After 3 months were conserved, but after 12 months we have lost the effect. The irritative symptoms that were decreased during treatment returned to baseline, and the other symptoms basically did not change significantly. So in conclusion, we can say that Caris Flow is, we know that easy to use, you already know, maybe. It is very well tolerated, and also you or probably already know this point with no side effect, and is effective on symptoms and signs of vaginal atrophy, at least in our samples, in our group of women in breast cancer survival. Improves sexuality because of the important effect on hydration and lubrification of the vagina. Relieve urinary symptoms in the short term, and in the long term we may discuss why it doesn't, or it loses its effect. But for most of the characteristics, for most of the parameters that we considered, there is a persistence of the benefit at 12 months. So this is very important because it gives us a perspective on how to use this type of treatment and how frequently to repeat the treatment in order to benefit and to respond to the need of the patient. Thank you very much for your attention.
Thank you very much, Professor Cagnacci. So, as usual, we let 20 minutes and we ask you if you have any questions, you can write in the chat. So Professor Cagnacci will be available to answer you and to help you. Don't be shy. I suggest, okay, let's check if the chat Okay, there are some regards for Professor Cagnacci. That means that you were very clear. Let's wait. If you have any questions on the study, any questions? Probably it's late, so everybody's tired.
Well, I may enter a little bit in the explanation for why some we have less response on urinary symptoms than or a recovery of the symptoms during the treatment. I think first of all because clearly the vagina is not the bladder is not the vagina, so the oxygen that is not directly delivered inside the urethra and inside the bladder. But we may also think that some of the benefit that are given on urinary disturbances and maybe are linked also to a reduction of urinary tract infection, low urinary tract infection, because of the benefit that caries flow gives on the vaginal flora, in the vaginal microbiota. There are several data showing that the administration of caries flow or vaginal oxygen improves the microbiota of the vagina. And so this is reflected with an improvement of also on the urinary disturbances. Now, then we have a loss of this effect because clearly when we talk about postmenopausal women or women in hypoestrogenism, like the one that we have, we don't have a maturation of the clearly in the absence of estrogens. We don't have maturation of the vaginal mucosa. Caries flow cannot stimulate the proliferation of the mucosa. It acts on the stroma, but not on the mucosa because the mucosa needs estrogen to maturate. And the maturation of the mucosa makes allows the production of glycogen that is the food for lactobacilli. So if you don't have if you don't have the maturation of the mucosa, you cannot have lactobacilli that are a defense against vaginal infection. So what you have with the caries flow maybe is an improvement of the infection, but this improvement in hypoestrogenic women cannot persist because you cannot reconstitute the normal vaginal flora, the normal vaginal microbiota because the hypoestrogenism. This is different in young women where caries flow may improve microbiota, and then improve the microbiota, the lactobacilli can survive inside the vagina, and so you create a new equilibrium, a new healthy equilibrium. In the postmenopausal women or hypoestrogenic women, if we don't administer together with the caries flow estrogens, local estrogens, we may lose the persistence of the fat.
We have now some questions. First of all, I would like to congratulate to Professor Cagnacci because I received a lot of congratulations for the webinar. And we have somebody that probably missed the beginning of the webinar, so they're asking the administration. So how many minutes you use the cannula and so on. And the second question is why are breast cancer survivors considered an important population to the study? And the third one is who is administrating the treatment typically? The gynecology, the nurses, or the physiotherapist?
Okay. Now, the first question is, I repeat, is the application. We did not invent this type of application. This was defined by Dr. Condemi before in physiological women, in women with physiological menopause. And we applied the same treatment. Is 15 minutes of vaginal oxygen through a intravaginal cannula. In the last 5 minutes, there is the introduction of an injection of hyaluronic acid that is delivered by the flow of oxygen without inside the vagina. So it's a 15 minutes application, and this application is repeated for 5 times every 15 days. So 2 months and a half of treatment with a treatment every 15 days for 5 times. The application can be performed by sanitary personnel, not physicians. In our institute are residents that usually perform this treatment, but I know from colleagues that they use nurses. It's very easy. It's just to put a cannula inside the vagina. The cannula is like an irrigator for vaginal douches, and open the oxygen flow, just keep the cannula inside the vagina for 15 minutes. So it's very easy. Why is important breast cancer? Because breast cancer, while women that did not suffer from breast cancer can use estrogens, can use any type of therapy, can use vaginal estrogen or ultra or DEA or other treatment to stimulate the vagina. Breast cancer survivor cannot use, at least during the treatment, when they are on aromatase inhibitors, they cannot use estrogens. So the hypoestrogenism that is induced by the aromatase inhibitors gives a rapid vaginal atrophy, a rapid devascularization of the vagina, a rapid thinning of the mucosa, and a big impact on their sexuality and their sexual life. So the only remedies that we have is either giving moisturizing agents, lubricants, or physical agents like laser or vaginal carriage flow. So this is why it is so important that carriage flow was effective in this group of women, because it allows us to give these women to treat these women, to give these women some relief from their disturbances.
Okay, thank you very much. I don't know if there were any other questions. No, probably not. So we really would like to thanks Professor Cagnacci. It was always a nice pleasure, and we are sure to organize something else shortly. Thank you so much for everything. And in any case, if in the next days you will have some questions, you can write us. We are always available to give you more information. There is another one, probably is the program used in both public and private healthcare? I can also answer to that. Yes, it's used in both, in public and also in private healthcare. Yes. Okay, also Natalie, okay, they would like to thank you again. There is another question. Yeah, it was very interesting. Good to hear that it's out there for this population of women. Yeah. Thank you so much. It's a pleasure. Okay, kind send us a recorded session. Yes, we will send the recording one for the person. Yeah, everybody, okay. There are a lot of people also, as I explained to Professor Cagnacci, especially in Japan or in Vietnam, people who has problem of timing that are expecting the recorded one. Thank you so much to everybody. Thank you again.